Craniovertebral junction surgery can create magic. Craniovertebral junction surgery can give new life. Craniovertebral junction surgery can give new life not only to the patient but to the entire family. Craniovertebral junction surgery is difficult. It is anatomical, biomechanical, technical. More importantly, it is philosophical. You have to understand this subject. You have to understand it perfectly. You cannot just say, let me try. You cannot say, let me see, or I will do. These kind of complex situations, either you touch or you don't touch. If you touch, you treat it properly, because you can give new life to this man and to his whole family. Or you devastate him. You completely finish him. Craniovertebral junction complications are the most devastating complications in the subject of spine. You can have a patient who is conscious, but he's not able to move his limbs. He's not able to breathe properly. He can not only trouble his own family, but trouble the doctor to the extent he's troubled and finished. Craniovertebral junction is like a human spine, human pillar. This V of the Y, this is the Y, this V is the craniovertebral junction. There are two important critical joints in the craniovertebral junction. One is occipital-atlantal joint and one is atlantoaxial joint. Atlantoaxial joint is the most mobile joint of the body. Occipital-atlantal joint is the most stable joint of the body. Mobility and stability are the hallmarks of craniovertebral junction. More the mobility, more the potential of instability. I want to give you some beautiful points. Atlantoaxial joint is the most mobile joint of the body. Atlantoaxial instability is the most common instability of the entire spine. Atlantoaxial instability is the most under-recognized and under-treated clinical entity in the entire subject of spine. And in my few lectures, I am going to elaborate on this issue. Atlantoaxial joint is the most mobile joint of the body. It is the most unstable joint of the body. Occipital-atlantal joint is the most stable joint of the body. Craniovertebral junction instability means atlantoaxial instability. Craniovertebral junction stabilization means atlantoaxial stabilization. Inclusion of the occipital bone in the fixation construct is a negative operation. Like yesterday we were discussing D11 fracture. So 2 segments up, 2 segments down, this is spine. But this craniovertebral junction is discrete. Craniovertebral junction stabilization can be achieved only and only if it is a segmental solid fixation. Atlantoaxial joint is a round and flat joint. It is a flat joint. No other joint is like this except sacroiliac joint. It gives circumferential movements to the body, to the head, circumferential. And it allows circumferential instability. That is the point. Circumferential instability can be here, here, up, down. Circumferential instability. Facets are the center of movements, are the fulcrum or point of activity of the atlantoaxial movements. all craniovertebral junction instability is centered on the facets or the fulcrum. Stabilization of the atlantoaxial joint means stabilization of the facets. This is my technique which I described in 1988. My techniques since 1988, 31 years, involves three crucial points. One is opening of the joint, removal of the articular cartilage, introduction of bone graft within the joint cavity, and then atlantoaxial fixation. For the first time, we also described screws. The screws, occipital screws, were described first by us. So this was my construct that we described in 1987. This construct has occipital fixation, one screw in C1 and one screw in C2. But that is history. Now today I ask you a question and I answer that question for you. Occipito-cervical fixation, is it necessary? I am saying it is not necessary. I am saying it is a suboptimal kind of fixation. I am saying it should be avoided. However, many a times atlantoaxial fixation is a difficult, complex operation. So if you cannot do the best, you do second best, and that is occipital fixation. Otherwise, never do it. I have completely abandoned this operation for several years. So this was my first case in 1988, and subsequently I have personal experience of more than 2,500 cases. In 1 year, last year, I did 210 cases in 1 year. And in 1 day, my maximum is 6 cases a day. So that is the extent of work volume that I am doing on craniovertebral junction. And that gives me an opportunity to understand this subject in a more wider perspective. C2 ganglion, if you see C2 ganglion, this we describe first, resection of C2 ganglion to open the joint. You see the joint, it is right in front of the joint. We describe first to resect, but now we do it very rarely. But understanding of the fact that you can resect the C2 ganglion without any major clinical implication completely revolutionized the field of craniovertebral junction atlantoaxial facetal fixation. Vertebral artery is, of course, quite a complex situation in several cases, not in some cases, not in few cases, in several cases. The C2 facet, the vertebral artery goes right into the C2 facet, making implantation of the screw quite challenging, difficult, and precise. This is a problem in a number of cases, which makes this operation difficult and dangerous. So unless and until you understand this anatomy of vertebral artery, the operation can be dangerous and difficult. We have recently started using, not recently, about few years, 3D models. So in complex situation, I make models using CT scan, MRI, all kind of radiological input. We make these models. And these models you can hold in hand. These are real human-sized models. And in complex situation, you can keep the model right in front of you during the operation, and you can continue with the operation. Beautiful model, beautiful operation. So you can look here, sometimes look towards the nurse, sometimes towards the anesthetic, but majority of times looking in the operation. Introduction of screw in a proper. So vertebral artery, you see the vertebral artery can also be seen in this model, and you can then exactly pinpoint where to introduce. So this is not real time, but in craniovertebral junction, the movements are not so pronounced. So this gives a very beautiful, many of my complex cases, I may not be able to do surgery unless I have these 3D models. So we describe these models first in the literature. So atlantoaxial dislocation historically has been diagnosed by altered atlantodental interval on flexion extension images. You do flexion of the head, there is instability, you do stabilization. So this is the standard anteroposterior kind of a dislocation. You see this standard dislocation, anteroposterior dislocation, we all know in os odontoideum, a very common clinical entity in craniovertebral junction. Atlantoaxial instability is the problem, atlantoaxial stabilization is the treatment. Beautiful thing I am going to show you, and please have a look. This is my position for surgery. I do under head high position, under cervical traction, and the head is floating. I call this floating head position. So head high under traction. This gives me a direct line of vision to the craniovertebral junction. It reduces the venous congestion in the field, this head high. It gives counter traction, and there is no pressure on the eyeballs or the face. Beautiful position. I don't attempt any neutralizing, like reduce the dislocation or anything. Just do traction and fixation under head high position in a neutral position. So this is my position. So if you divide the pars and pedicle into 9 quadrants, obviously the medial quadrants and medial 4 quadrants are safer, but they are not always safe. The vertebral artery can be in jeopardy even in this situation. So the basic trick of operation is understanding of the vertebral artery and avoiding the vertebral artery during surgery. So this was a smallish modification that we did to our technique, 1 screw in C1 and 1 like Megel technique. Essentially, facetal fixation is the treatment, and Megel fixation and this combined gives a double insurance kind of a situation. So this is the dislocation and 1 screw in a transarticular kind of fixation. Also, we described with my friend Arvind Kulkarni, he's here, I'm not sure Arvind is here. We described for the first time in the literature laminar screws. Of course, like many other techniques of mine, they have never been credited to me, but this is the paper and this is the technique where we introduced the screw in the lamina and in the spinolaminar junction, and we used it to stabilize the axial part of the occipito-axial construct. So this was the image in my article on during that time. C2 vertebra, C2 axis vertebra is an atypical vertebra. One is that there is a odontoid process. This is atypical. Second atypical thing is the facet of superior facet. This is the superior facet, this is the inferior facet. Superior facet is rostral and anterior to the inferior facet. All other facets are in a pillar, but you see the superior facet is here, inferior facet is here. The vertebral artery is in relationship with the superior facet and never with the inferior facet. So we described that when we cannot introduce the screw in the C2 facet due to the vertebral artery, you can use the inferior facet for fixation in, of course, quite rare situations. And in a rarer situation, you can do transarticular C2-3. So you see the vertebral artery is in a little bit of a compromising situation. So you put 1 screw here and 1 screw in the inferior facet. Of course, this is an extremely rare situation. I can tell you, and many people ask me, you enter into C1 area, how many times you have to abandon the procedure to do occipital fixation? You see the kind of complex cases that I am treating, there are occasions when C1, C2 fixation is a difficult position. But never I have incorporated the occipital bone in the fixation construct for several years. Earlier, of course, I used to do it. We also discussed the use of intra-articular spacers for the first time in literature, intra-articular spacers. Then we used it for the cervical spine, and then we used it for lumbar spine. But metal implantation in the facet was the first time described by us, and we call this technique a joint jamming technique. And many of you who use this technique for distraction of the facet and reduction of basilar invagination. The another remarkable, I think a revolutionary introduction in the field of craniovertebral junction was manipulation of the facet. Manual manipulation, open the joint and manually manipulate the facet, completely revolutionized the field of craniovertebral junction, completely. We also said that there is nothing like fixed atlantoaxial dislocation. All dislocations are reducible. There is nothing like fixed. So this kind of entity was called a fixed. It doesn't move on flexion and extension, but you open the facet, manipulate the facet, and you can reduce the dislocation. Reduction of a fixed atlantoaxial dislocation, which was published as cover page of Journal of Neurosurgery, revolutionized the field of craniovertebral junction. Basilar invagination has been treated for several decades. Transoral surgery has been the hallmark, the basis of treatment. Transoral surgery. This article for the first time mentioned that there can be a reduction of basilar invagination. There is a possibility to reduce basilar invagination. There is a possibility to do craniovertebral realignment.